good afternoon. It's a great pleasure to be here today in the Long Gallery. It's a lovely building. My name is Professor Karola Dillenburger. I'm from the Centre for Behaviour Analysis at Queen's University. And I'm going to talk to you about early intervention in autism spectrum disorders. And I'm going to be looking at comparing international policies with the developments in Northern Ireland, because an awful lot of things have happened in the area of autism in Northern Ireland over the last 3 or 4 years. And it's maybe time to have a look at what's happening internationally. Generally speaking, the diagnosis of autism is given when there are social communication deficits and restrictive interests and repetitive behaviours. Sometimes, or very frequently, there are also sensory issues. But overall, whenever we're talking about autism, it is a behavioural observations and it's the reports from the parents that allow us to give the diagnosis. There are no medical tests at this moment in time for autism, quite different from some of the other learning disabilities. Maybe with Down syndrome, you know there's a genetic issue happening. With autism, we don't have any genetic information at this moment in time that we know that would identify somebody with autism. So the question is autism a lifelong disability? That is a term that's very often used. And I want to go into some of these issues first before I go into see what the international best practice shows us and how we compare with that in Northern Ireland. It's really important to know that autism does not only affect children. There's also adults with autism, and sometimes people say a child with autism grows into an adult with autism. But the concept of lifelong disability limits the expectations of the trajectory. It puts like a lid of the expectations. And we find now, I'm sure you've seen recently in the news, that 1,300 children are waiting for a diagnosis in autism in Northern Ireland. And part of that is due to the fact that health services are reluctant to give an early diagnosis for these children in case, because they don't want to label a child very young with a lifelong disability. So we need to have a look at, is it really necessarily a lifelong disability? The NICE Institute, in their latest report, is really replacing the term lifelong with a chronic disorder with lifelong disability for some individuals. They're starting to realize that it doesn't have to be necessarily lifelong as a disability. Most people that receive very good early intervention, they can develop, or many people can develop behaviors that don't meet the diagnostic criteria anymore afterwards. It doesn't mean to say that they don't have autism anymore, but it is not as a disability that it affects them lifelong. So there are very many advantages in early diagnosis. It gives you access, it gives parents access to early behavioural intervention where it is available. It also gives carers and access to carers and disability benefits, and it impacts on the future. There's also disadvantage because is it a lifelong label, and does it have impacts on the future in terms of giving an early diagnosis? So it is important to think around those things. There is a reluctance to give early diagnosis, and yet sometimes that can actually hinder the process and the progress. In terms of cost, it's difficult to talk about cost of autism because people sort of say we can't put a cost on autism, but people have done cost-benefit analysis and found that depending on the level of autism on the spectrum, because autism is thought of as a spectrum, with some people coping quite well and other people needing a lot of support, especially those people who have a co-occurring learning disability. So the cost is quite a spectrum as well, but it can cost up to nearly $1.5 million across a lifespan to support somebody with autism. Annually, the UK is spending £32 billion on autism services and interventions. But with good intervention, people are saying, the research has shown that up to £1 million can be saved over a lifetime. But what is that good intervention? That's really the question I want to address. Where do we turn with autism interventions from here? Well, in the USA, in America, it was interesting to hear you talking about the Surgeon General. The Surgeon General also brought out a report in 1999. So that's 15 years ago. But then he said that over 30 years of research, and now that would be 45 years of research, have demonstrated the efficacy of applied behavioural methods in reducing inappropriate behaviour and in increasing communication, learning, and appropriate social behaviour. Okay, so he is talking about very clearly saying that there are applied behavioural methods that should be used to help these people. So what is behaviour analysis? There's really 3 aspects to behaviour analysis. One is the conceptual analysis, which basically just looks at understanding behavior, researching behavior, and it goes to the root of behavior. The second one is the basic science. Like in any other science, it has a basic science where they're studying in the laboratory, but the experimental analysis. And then we have the applied side of the science, which is called applied behavior analysis. And some of you in the autism world have probably heard of ABA. Sometimes that is very badly misunderstood as being one intervention in autism, when here you very clearly say it's the application of a science that looks at individually tailored approaches. So like all the other sciences, behavior analysis is taught at university, master's and doctoral levels. So the definition of applied behavior analysis is a discovery of environmental variables that reliably influence socially relevant behaviors and develop interventions for behavior change that take practical advantage of discoveries from the experimental analysis of behavior. So what an applied behavior analyst does, he or she takes the findings from the experimental analysis and applies it to socially relevant behaviors. And that is really important, because sometimes people sort of think, well, do we want to teach people with autism specific behaviors? Well, as far as this is concerned, we want to teach them socially relevant behaviors. And obviously, that is very individually different. What is socially relevant for me might not be socially relevant to yourselves. It really depends on the family circumstances. It depends on the age of the person. So nobody's saying that people should be taught specific behaviors, but they should be socially relevant for that person's context. In the USA, in America, the Office for Personnel Management concluded that there is now sufficient evidence to categorize ABA as medical therapy rather than purely educational. And also, Capitol Hill, the American Academy of Pediatrics, publicly endorses the use of ABA treatments. And another one in the Department of Health and Human Services, a growing evidence base suggests that behavioral interventions can be associated with positive outcomes for children with ASD. So here is a science that is actually targeted, when targeted for people with autism, can actually help, and in the US, in America, is now helping increasingly. Here's a map of all the dark green states. In fact, it still says 37. There's now 38 because Washington has also adopted it. Most of the US states are now adopting ABA-based services for children with autism, and most of them also have laws that mean that these services are not just aimed at children, but also across the whole lifespan where necessary. And exactly the same is true also for Canada. The Ontario Ministry for Education has said in their policy program memorandum that they establish a policy framework to support incorporation of ABA methods into school board practices. And they have gone even a step further, and they said that the absence of these kinds of interventions mean that children with autism are excluded from the opportunity to access learning, with a consequential deprivation of skills and the likelihood of isolation from society, and the loss of the ability to exercise the rights and freedom to which Canadians are entitled. And I think this is a very strong argument for us to really get to grips with applied behavior analytic interventions for children and also adults with autism. In Australia, again, the Department of Families, Housing and Community Services has classed applied behaviour analysis and early behaviour interventions as eligible based on established research evidence. In fact, out of all the intervention frameworks that they have assessed, this was the only one that was eligible. That was the green one, that was ER, eligible based on established research evidence. Some other ones were recommended on emerging evidence, but this was the only one that was actually already established evidence. So what are we going to do in Northern Ireland? In Northern Ireland, as you all know, we have the Autism Act since a couple of years ago, and this January, we also had the launch of the Autism Strategy and the Autism Action Plan for the next 3 years. In fact, I suppose we're already well into the first year of that. So we have moved quite some way in terms of autism in Northern Ireland. We also have the NICE guidelines, and a lot of people in Northern Ireland would follow the NICE guidelines for diagnosis, for adults, and for the management of children. But the problem is that none of these documents included any recommendations for ABA-based interventions, and that's really the crux of the argument that I want to put to you today, and that's where we have to take it from here. We see that in the USA, in Canada, in Australia, they are very clear as to what kind of interventions, what kind of early interventions they want to have for their children and young people with autism. We have seen that these interventions are based on a very large, well-established science, well-established research base, and yet none of our documents in Northern Ireland recommends any of these interventions. In fact, the NICE review said that the review of the evidence, the guideline development group, found no evidence in support of ABA and therefore could not make recommendations about ABA. So to me, that's quite a shocking circumstance where we have the established evidence internationally in all these, and they're English-speaking countries. It's not as if the research is conducted in a foreign language. We do understand the language in those countries, so we should be able to read the research. We should be able to include that in Northern Ireland, but we don't. So let's see what we are actually doing in Northern Ireland. The Northern Irish approach to autism is eclectic. When you look at what eclectic means, and I found it quite difficult actually to find a definition of eclectic, deriving ideas, styles, and tastes from a broad and diverse range of sources. When it comes to interventions, what it means an assortment of educational and therapeutic techniques that are as varied as the school districts from which they come. So basically, it's what we do at the moment, with no particular, I'm not saying that the people that are doing these interventions are not very loving and caring people, because they are. But what we're doing, we haven't got a proper policy that gives us a proper guidance as to what we're doing. The eclectic approach basically includes a whole range of different intervention methods. And basically side by side, and they get picked pretty much, at the moment they get picked, selected pretty much on the basis of what the staff knows, what the staff can do. Okay, not what is best international practice, but what are we doing, what have we always done, right? So the Northern Irish approach to autism is eclectic, and that means it's really a one-fits-all approach. It means comprehensive training in eclectic methods is impossible. You can't be trained in all of those methods. It means who makes the decisions about what to include and what to exclude? Who makes those decisions? It means the eclectic approach does not have a coherent theoretical knowledge base, because all of these interventions come from different directions. So what you have is somebody, maybe in the morning they get one, in the afternoon they get something else, and there could be conflicting theoretical frameworks underpinning these interventions. They also very often, so they could be conflicting, yeah, they also very often don't have an evidence base. Some of these interventions have an evidence base and some of them don't, but they're all mixed into this eclectic mix. We also can't control for the synergy effects, so we don't know if you take these two, does it have a different effect than if you have those two together? Because of course when you have one intervention, that affects the next intervention as well. So, and there's no evidence of effectiveness. So what happens with the eclectic long-term outcome? What we have seen recently, it was actually Patricia Howland's finding of a study. They had 60 people that were diagnosed some 40 years ago by Professor Michael Rotter, and they came back to those people 40 years later. So by this stage, the average age of the people that they researched was 44 years of age, and they measured cognitive language abilities at 6 and then at 44 years. The findings were that 15 of those people were untestable because they had such severe aggressive and self-injurious behavior, severe language delays. 44 participants in the study, the IQ and the language had been stable. The IQ had been stable, the language had improved a little bit, but stable from they were 6. Okay, so there's no development from 6 in terms of IQ, and at 44 years of age, they still had the same IQ. Language had improved a little bit. And what they concluded was that many had attended the specialist autism school as children, but none had access to the intensive early behavioural ABA-based programs that I've just described. Okay, so in contrast, so whenever we are doing what we're doing, if we continue to do what we're doing right now, that's going to be the outcome of the children that are 6 years old now, because that is what we're doing right now in terms of intervention. We do not give them access to the early behavioural interventions that we know work. We don't have them in Northern Ireland by and large. We have a very small charity really that is the only charity that promotes this particular type of thinking and intervention, and the trusts are referring their parents who want this intervention for their children to the charity. That can't be right. There's nobody in the statutory sector that is really promoting this intervention or ABA-based interventions. In America, where they have this support, they have studies of optimal outcomes. That means optimal outcome means that these people, they were diagnosed with autism when they were very young, just the same as our kids here. But with the right intervention, 25 to 47%, they do not meet the diagnostic criteria anymore. Okay, the diagnostic criteria that we have seen with little Jake early on, and that I've shown you. So a quarter to nearly half of the people do not meet those criteria anymore. I'm not saying they don't have autism anymore, because they might have some problems in other areas, but they're not meeting the diagnostic criteria. They are not clinically relevant anymore in terms of that. So what was the cost for that in America? The cost in America was 26 cents. That's 50p per member per month. Okay? So is anybody worried about that? Is anybody worried about paying 50p to help these children to develop optimal outcomes? I would say we could probably convince the population very quickly that that is a very small price to pay. So what they have found is statistically significant links between optimal outcomes and ABA-based interventions. The ABA-based interventions have to be early, and they have to last for about 1 to 3 years. That was where the statistically significant relationship was lying. Now, what we have here is that a lot of people think they don't understand what ABA is. They make a category mistake, and I've just drawn this little picture to show you what I mean when I say a category mistake. If you show somebody mother, father, child, and uncle or aunt, and then you say to them, now show me your family. Do you see what I mean? It's two different categories. I've drawn it out. The family is a bigger category, and then you have all the people in the family. Does that make sense? If you say to somebody, show me the bedroom, living room, kitchen, and bathroom, and then you say at the same time, now show me your house, but you've just seen the house. So what happens here is that people say, we're doing LOVAs, we're doing PECs, we're doing verbal behavior, we're doing all sorts of things, and we're also doing ABA in our eclectic mix. So they're misunderstanding that ABA is the overarching concept, it's the overarching category. It's the science, the application of the science. It's not one intervention. It is the theoretical underpinnings of a whole range of interventions. And I've drawn another little picture. I think this makes it quite clear. So if we have ABA as a knowledge and the ethics, the knowledge base, the science knowledge base, and then we build extra knowledge on autism on that one, because of course with the science of behavior, it could be applied to all sorts of areas. We happen to talk about autism at the moment, but it could be applied to a whole range of areas of other disabilities, but also of typically developing classroom management, organizational management, or whatever. So if we build the science, on the science of behavior analysis, we build knowledge of autism, then we can work out a whole different range of, and I'm not expecting that you can read them all. I think some people have handouts. You can build a whole range of different individually tailored interventions, because you have that big knowledge base. It's a little bit, if you say medicine and chemotherapy, right? As if you're putting them in the same category. So saying, I've got chemotherapy, now show me medicine. It doesn't work, okay? And sometimes people say, well, with ABA, you want to treat everybody the same. That's like saying every doctor wants to give you chemotherapy regardless what's wrong with you. Okay, that's just silly. That's not what people want to do, obviously. That would be silly. No doctor would agree with that. Okay, chemotherapy is one intervention, like one of those for one particular diagnosis, okay, or one particular thing that you need it for. Does that make sense? So, do we have the evidence that this works? There have been thousands of replicated single system design studies. There have been randomized control trials, and I'm not going to go into the detail. I can give you reference lists if you want. There have been lots of meta-analysis. There have been sequential meta-analysis. There have been systematic reviews. There have been neuroscience. There's been brain scans. There have been social validity measures, and there have been cost-benefit analysis. And as I say, I can give you references if you want. So, does ABA change the person? Well, autism is diagnosed on the basis of behavior. And what does ABA do? It wants to discover environmental variables that reliably influence social significant behaviors. That's the definition that I put up at the beginning. That is what we do when we do behavior analysis. We take practical advantage of the discoveries from the experimental analysis. Do we want to change the behavior? What way do we want to change the behavior? We're looking at socially significant curricula. Who determines those curricula? They are determined by the individual or by the parent or caregiver. Just depends on the age of the ability levels of the person that we're talking to. they very often are around life skills. An awful lot of the parents tell us that really the academic skills is really important, but really it's all about life skills. And when we do research, you were talking about the older caregiver and the aging. When we do research with older caregivers who are looking after these adults with autism and learning disabilities, it's the problem behaviours, the difficult behaviours that are causing the biggest worry. If they don't have problem behaviours, then it's about physical care or it's about organising their social life or something. But if they don't have challenging behaviours, then people can cope with them quite well. But when they have life skills, then it makes life a lot easier for these ageing carers. Academic skills are obviously important as well, because we have a national curriculum that we want to try and achieve with these people, with these children, just the same as everybody else. But basically, all the skills, the socially significant curriculum in behaviour analysis would be all the skills necessary to lead a fulfilled life. And they're exactly the same as for any other child. Okay, so when we say, sometimes people say, well, we shouldn't be doing this and that and the other with a child with autism. To me, that's quite discriminatory, because I've got 4 children. I would want, if one of them had autism, I would want exactly the same things for that child than I wanted for the other 3. Okay, so it's about skills development to increase choice. Social validity measures are really important, because we can know the science, we can do everything with the science, and this can be very good, but if it's not socially relevant to the people that we're working with, the families that we're working with, it's pretty useless and it won't be used. So we're looking, in behaviour analysis, we're looking at the social importance and the clinical acceptability of treatment goals, procedures and outcomes. So it's really important that we have all 3 of those. And when we ask the parents about that, 90% of them say that these kinds of early interventions have actually socially valid, and they reduce stress levels. What's really intriguing for me as a researcher and as an academic is that when we do this kind of research, we get all sorts of critique. And one of the most interesting critiques we get is that, yeah, it's you behaviour analysts are doing all this research, so not about a wonder you find it works, right? And I'm sort of thinking, well, if somebody was doing dental research, who should do the dental research? Should it be the weatherman? Should it be the behaviour analyst? Should it be the fisherman? Or should it be the dentist? Right? But what about if somebody would do meteorological research? Who should do that? Should it be the behaviour analyst, the fisherman, the dentist, or the weatherman? So when it comes to behaviour analytic research, same logic applies. Should it be the weatherman, the fisherman, the dentist, or should it be the behaviour analyst? So it's kind of a very odd critique that we sometimes face, but I'm just showing you that it's very difficult to get this science into the treatment, not the treatment literature, but into the treatment for the people. And one of the reasons in Northern Ireland is that we have a great lack, in Europe generally speaking, we have a great lack of training for behaviour analysts. There's a job title called Board Certified Behaviour Analyst, which is a master's level qualification. And both universities in Northern Ireland run master's courses in behaviour analysis. So you take your pick. University of Ulster is running it on campus. Queen's runs it online. So you can take your pick where you want to train. And it's actually quite intriguing that we have relatively few Northern Ireland people on the courses. We have a lot of international people. We have a lot of people from down south on the courses. We have Northern Irish people, but they're self-funding. We don't get people sent from the trusts or the education library boards onto these courses. And these would be exactly the courses they should be taken, in my view. And I would encourage people to think, right, okay, some of these modules can also be taken as short courses, so you don't have to take the full master's straight away. You can take your time, working your way through the master's. These master's courses have 270 hours of training. What happens very often in this area is that people say, well, I've been on an an autism course I've listened to for 2 hours. Somebody says, we are training thousands of people, but when you look at what training is actually going on, it's a 2-hour talk. It's like me saying, I've talked to you for 20 minutes, I've just trained you in autism, or I've just trained you in ABA. That would be just silly. The training in behaviour analysis is 270 hours in class, and then it is 1,500 hours in practice. So that equates to about a year's placement of supervised practice. Like any other profession, you have that in all the other professions, about a year worth of experience. You can also obviously then train up to a doctoral level as well. And then when you've done all of that, then you're eligible to take an exam to become a board-certified behaviour analyst. There's also assistant behaviour analyst, but that's pretty much, it's an undergraduate qualification. And we have, for the direct face-to-face practitioners, we have a registered behaviour technician training which is 40 hours curriculum. So when you think of those kinds of trainings, and these are all available in Northern Ireland, so it's very intriguing to know that we're actually not training our staff in Northern Ireland well enough to do the kinds of things that we should be doing, that we know we should be doing. So if anybody has any sway with the training providers, send them to the universities. You've got 2 excellent internationally recognized universities, and I'm speaking for myself, and we'll hear from Stephen, and we have already heard from Lawrence, of course. We have 2 excellent universities that offer this kind of training, and I think we're not availing of it well enough from the trusts and the education library boards. And I've got a load of references, and as I say, I can give you more if you want it. Thank you very much.